Bonjour. So thanks for the kind invitation and introduction. So let's talk today about rectal cancer and MRI. I have nothing to disclose. So MRI is the imaging gold standard for rectal cancer because it changed completely patient management. At baseline, MRI will help selecting patients between neoadjuvant therapy or surgery. After chemoradiotherapy, MRI will decide about the surgical approach, will evaluate the response after treatment, and even replace the surgery in case of a complete response at the era of the watch and wait approach. So let's talk about the MRI and rectal at baseline. So MRI at baseline will help selecting patients for neoadjuvant treatment and identify poor prognosis parameters. So there are wide variations between continents, between countries, and even within surgeons about which treatment approach is the best. However, very schematically, usually the good prognosis lesions, such as the T1, T2, or for Europe, the middle or high T3AB without node, with a mesorectal fascia clear and without extramural vascular invasion, are usually referred for surgery. The T3CD and 4 with node positive, or with a mesorectal fascia involved, or with extramural vascular invasion, are referred for neoadjuvant treatment. And then we have this intermediate lesion, the T3AB low-lying but with a mesorectal fascia clear, or the T3AB within the mid or high rectum with positive node. We are in the middle, and there is not really consensus for them, and they may be referred for surgery or neoadjuvant treatment, provided the surgeon have very good results for total mesorectal excision. So nevertheless, MRI is really important in this setting because it will evaluate all those prognosis parameters, the T staging, the location of the tumor, the end stage, the mesorectal fascia involvement, and the extramural vascular invasion. So in these few minutes, we will review the protocol, the need of structured reporting, the staging system, and the new quantitative MRI parameter we can use at baseline. So for protocol, there is no consensus regarding the use of spasmolytic. It can be of help, especially for mid and high-lying tumor, because it will decrease the bowel movement. For rectal filling, it's not recommended as well, because it can increase the rectal lumen and decrease your distance between the mesorectum and the tumor. Like here, you see it's decrease the distance. However, sometimes it can be of help if you have a very small tumor after treatment. So what is recommended if you want to use gel is to use very small amount of gel. Enema are not recommended. However, very recent study demonstrated the added value of enema, especially in diffusion, because it reduces the susceptibility artifact related to hair. So, for example, in this patient, at the lower aspect of the tumor, the rectum is collapsed, and as such, you have really nice diffusion. However, at the superior border of the tumor, you see there is hair and susceptibility artifact. So the diffusion and especially the fused image are not very good. So enema may be a possibility. So what about now the protocol? For that, I would refer you to the updated SCAR or SAR guidelines, and it's a very simple protocol between 16 to 20 minutes, only sagittal, axial, and coronal T2 seconds plus diffusion, no fat-sat, no injection. So the sagittal T2 enables the tumor location and place your very important main sequence, which is the axial oblique T2 sequence. It has to be in thin section, and you will look at the invasive border of the tumor and do perpendicular plane at this aspect. Then you have the coronal oblique sequence, which is really important, especially in a low-lying tumor, because you want to assess the sphincter involvement. and then the diffusion sequence mainly for post-treatment assessment. So just as a few examples, in this mid-lying tumor, as you can see, it looks like it's a T3. But if you look closely, the slice thickness was 5 millimeters. And if we do a 2.5 millimeter, the muscularis propria is completely intact and it was only a T2. In this other case, you see a large, really large tumor, and it looks like again a T3, but check the cross-reference. The plane here was this. If you do a proper plane, it's completely a T2, so it really changed the management. So great protocol, make great report. As this example, you do perfectly perpendicular axial sequence, and you have thin section, and you see perfectly the anatomy of the muscularis propria and the tumor. You can even fuse with the diffusion, and as you see here, you have this nice polypoid lesion with this vessel feeding the lesion, as you can see here on the correlation. So for more information about the protocol, I would refer you to the Abdominal Radiology DFP rectal cancer webpage, where you can find for each brand and for 1.5 and 3 Tesla all the example of protocol. So what about now structured reporting? So in 2013, this study demonstrated, they calculated in how many cases the T staging, the N staging, and the CRM was reported in the report. And it was only in 30%. So it was very low. So since then, multiple studies have evaluated the role of a standardized reporting in order to improve the quality of our report. And I really encourage you to use a structured report. There are multiple online available. The ESGAR proposed one structured reporting. The SAR guideline proposed structured reporting. So you have many available. You can make one, but what I would recommend is to use one. So what about now the staging of rectal cancer? And for that I will talk about my little mnemonic to assess all the key finding to select patient for good or poor prognosis. So it's distance for the distance from the inferior part of the tumor to the transitional skin, the T for the T staging, the A for the anal complex, the N for the N staging, the C for the circumferential resection margin, and the E for the extravascular mural invasion. So let's talk about the dis and the distance. So on sagittal T2 plane, you will divide your rectum into three parts. So the low rectal tumor from 0 to 5, the mid rectal tumor from 5 to 10, and then the upper rectal up to 10 to 15 centimeters. So you will give the surgeon three measurements. One measurement from the anal verge to the inferior part of the tumor, one measurement from the puborectal sling to the inferior border of the tumor, and the craniocaudal length. This sagittal T2 sequence is fundamental again to place your axial T2 sequence, which will give you the T staging. So on MRI, the T staging at baseline has a very good accuracy, around 80%. So what you will say is whether the tumor is confined within the muscularis propria or is going through the muscularis propria and invading the mesorectum. We know that the depth of extramural spread is a key factor for prognosis and overall survival. So if the tumor is going more than 5 millimeters within the mesorectum, the overall survival is around 50%. So the T staging is the first key factor to decide whether the patient needs surgery or a neoadjuvant treatment. So how to evaluate the extramural spread? So first, it must be again assessed on plane strictly perpendicular to the tumor, and then you will find the invasive border of the tumor, which is usually centrally located, and you follow the very nice low signal intensity of the muscularis propria and look for any disruption. So like here or like here, and you look for disruption. So now let's move to the A and the anal canal. So for the anal canal, you will use this nice coronal T2 sequence really parallel to the anal canal to assess the invasion of the sphincter. So just to summarize the anatomy, the muscularis propria is going below to be the internal sphincter, and the puborectal is going to be the external sphincter. And in between, you have this virtual space, the intersphincteric space. And as you see, there is no more mesorectum. And this is a problem for surgeons, because at the anal canal level, wow, how they can have free margin. This is getting difficult. So this is the main problem, and this is why low-lying tumor need really to be assessed at baseline, because you want to send the patient to neoadjuvant treatment if he needs to have an amputation, because you want to avoid this amputation. So just schematically, what is the usual treatment for those patients? If the tumor is lying above the puborectal sling, it's fine. They can do a low anterior resection. If it's lying below, and if just contained within the internal sphincter, they can do an intersphincteric resection. However, if it's going within this space, or the puborectal or the external sphincter, they need to do an amputation. And this is why you really need to assess all these parts, because you want really to have a shrinkage with your neoadjuvant treatment or even a complete response in order to avoid any really big surgery such as an amputation or some very not preservative surgery. So how to evaluate the anal canal? So first you will do coronal high resolution T2, and then the first question is to locate the tumor, whether it's above or below the puborectal sling. If it's above, you are fine. There is no risk of sphincter invasion. If it's below, you need to evaluate all those four areas: the internal sphincter, the intersphincteric space, the puborectal muscle, and the external sphincter. And like here, you can see the tumor is going down, there is an extension within the internal sphincter, and this patient needs an amputation. So what they can do, they will do neoadjuvant treatment in order to have a tumor shrinkage and try to avoid this amputation. At the end, this patient got a complete response and now is just on a follow-up. So what about nodal staging? So usually, when you have a positive node at baseline, it's mean neoadjuvant treatment. There is some debate for mid and high-lying tumor, which can go directly to surgery. However, nevertheless, you really need to assess the node as baseline. The problem with node is we always overstage, like in 25%, the node positive. So what are the criteria for evaluating node? So the morphological criteria are very poor, with the size, which has a very poor specificity. You can increase, with some study we have shown 85%, I would say it's a little bit less, like around 60 and 70%, the irregular border, the round shape, and the homogeneity as suspicious morphological feature, which increase your specificity for malignant node. For that, I really would refer you to the ESGAR guideline, where they propose a very nice algorithm to assess node malignancy. So a node has to be considered as malignant if the diameter is more or equal at 9 millimeter, or if it's between 5 and 8 millimeter and with two morphologically feature, or if it's less than 5 millimeter but with 3 malignant feature. Those are the mesorectal nodes. However, one thing to memorize is look outside the box. You need to look to iliac node and pelvic sidewall node at baseline, because it will change the radiotherapy field and it will change the patient management. So those nodes are really important to assess at baseline. What about diffusion? Diffusion weighted imaging and nodes. So it's perfect for detection. You will have a roadmap of all the nodes, but it's really, really poor specificity. Some tremendous work has been done about USPIO and gatofovesept. They have shown both that there is an improvement of specificity, however, they are no more available, and maybe with the coming of the PET MRI, we may change this nodal staging. What about circumferential resection margin? So the circumferential resection margin is your surgical plane and corresponds to the mesorectal fascia. You need to know that anteriorly and superiorly, there is no more mesorectum. The mesorectum fused with the peritoneal reflection, and as such, you can't really tell about CRM anteriorly and superiorly. So how to assess the circumferential resection margin? So first, you will outline the very low signal intensity representing the mesorectal fascia, and then you will look for any nodes, tumor deposit, extramural vascular invasion lying within 1 millimeter between the mesorectal fascia and the tumor. And this will be a positive mesorectal fascia. Let's finish with the extramural vascular invasion. So this is a new parameter, and it's basically tumor within the vessel. It's a very high risk factor for distant metastasis, for local and distant recurrence, and worse overall survival. At our institution, when we saw extramural vascular invasion on MRI for the rectum, the patient gets a liver MRI in addition for the CT in order to detect the little liver mets. So how to evaluate extramural vascular invasion? Well, you look for presence of signal intensity within a vessel, expanded or disrupted vessel. So here you have very thin, normal vessel. However, if you look at those, they are expanded, very subcutaneous, feeding the tumor, or just collapse regarding the tumor. This is extramural vascular invasion. So at the end, you will have your perfect protocol, perfect sequence with perfect structured reporting, which led you to differentiate between good prognosis factor and poor prognosis factor to help better selecting the patient for neoadjuvant treatment or surgery. But those are subjective qualitative features. Is there any new quantitative data which can serve at baseline as a surrogate of treatment response? So what about the ADC? So the ADC has shown some conflicting results. There is multiple now study about baseline ADC to predict response. So before chemoradiotherapy, before chemoradiotherapy, poor responder have a tendency to have higher ADC, maybe related to necrosis, but there is huge overlap and we need further study. What about perfusion? At baseline, it has been shown that an increase in case strength was associated with good responder. And more recently, an increase of case strength was associated with a complete response. On the other hand, it has been shown that the lead slope could be of help, as lead slope was lower in a good responder compared to the poor responder. As we enter the era of artificial intelligence, what about radiomics? So you know that radiomics is the extraction of multiple quantitative features from the image to correlate with a diagnosis, a prognosis, and a survival, or even a genomic pattern. So it has been shown that after treatment, you can better predict with the T2 matrix the complete response compared to the subjective analysis. Few preliminary studies have been evaluated radiomics at baseline, and the results are pretty encouraging. So texture analysis may predict the initial T staging and may predict as well treatment response. So further study will be needed. So now we can guess that in the coming years we will have some completely automated software which will extract multiple features that we can combine with our subjective qualitative assessment to better evaluate those good and poor prognosis factors, to better refer patients either for surgery in order to avoid all the complications of chemoradiotherapy, or to refer them for neoadjuvant treatment when they really need it, and in order to decrease the risk of recurrence. Thank you for your attention.